Endomyocardial diseases represent a diverse group of conditions characterized by pathological changes in the endocardium and the adjacent myocardium. These conditions often lead to restrictive cardiomyopathy, heart failure, and systemic complications. Two primary conditions falling under this umbrella are often discussed together due to their clinical similarities, though they are geographically and etiologically distinct. Endomyocardial fibrosis or EMF is primarily seen in tropical and subtropical regions like Africa, parts of India, and South America. Progressive fibrosis of the endocardium involving the apex and inflow tracts of the right or left ventricles or both. Disease progresses through an initial phase of acute myocarditis, later leading to necrotic and thrombotic phases, and finally the fibrotic phase. It is the fibrotic phase which usually presents as EMF to the hospitals. Etiology is largely unknown, but theories suggest links to dietary toxins, example that in cassava, malnutrition, serum levels, and infections like parasites. Low fluorescence endocarditis in hypereosinophilic syndrome has a global distribution. Pathology is somewhat similar to EMF, but associated with severe chronic peripheral eosinophilia. Symptoms usually reflect restrictive physiology, where the heart becomes stiff and cannot fill properly during diastole. Right heart failure with jugular venous distension, hepatomegaly, ascites, and peripheral edema. Left heart failure can manifest with dyspnea on exertion, orthopnea, and pulmonary congestion. Arrhythmias like atrial fibrillation can occur due to atrial enlargement. There is a risk of systemic or pulmonary emboli from mural thrombi. On echocardiography, the hallmark is obliteration of right ventricular apex by fibrosis or thrombus. There is marked enlargement of the atria in endomyocardial fibrosis, especially the right atrium, which can be quite giant. Systolic function is normal or slightly reduced, but there is severe diastolic dysfunction. Tethering of the atrioventricular walls can occur, leading to mitral or tricuspid regurgitation. MRI is superior for tissue characterization. Late gadolinium enhancement typically shows subendocardial enhancement in a V shape at the apex. A double V shape has also been described. It has better sensitivity than echo for identifying apical clots. While endomyocardial biopsy is probably definitive for seeing eosinophilic infiltration or dense collagen deposition, it is often avoided due to the risk of dislodging thrombi or sampling error if the biopsy misses the fibrotic patch. Treatment focuses on symptom relief and preventing complications, diuretics for congestion, and anticoagulation for thrombus prevention. In low fluorescence, steroids or other drugs in unresponsive cases like imatinib are used to lower eosinophil counts. Endomyocardial decortication, that is surgical removal of the fibrous peel, and wall replacement may be necessary in advanced cases. Prognosis is generally poor once the restrictive symptoms appear, necessitating close monitoring for heart failure progression.